Okay.
Yes, sir.
Yeah. So Charlie
Right.
worked on the how to reduce the infection rate, and one of the important thing he did was the laminar flow. And this was the engineer Sir Hugh Howard. He is the man who developed actually laminar flow, and it is called Howard laminar flow system throughout UK. And he also had what is called as a greenhouse. If you see this picture, this is a tent, a greenhouse tent, and actually the patient head is outside, and operating surgeons are inside, and the trays, different trays will be passed. First the preparation tray, second the incision tray, and gradually the acetabulum, femur. That is the way the sets were going inside. So there was no traffic inside except the operating surgeon and assistant. So that was the important concept of greenhouse that Chandra developed. And with this, he brought the infection rate, which was 3.4 infection. He brought with ultra clean, that is a body ultra clean system, that is a laminar flow system. He brought it to 1.7. Then he added body exhaust, and then he brought it to 0.075. And then he started antibiotic protocol for a first 1 or 2 days or 3 days initial period, and then he brought it to zero point 0.2. So that is the way this was important to reduce infection rate, and there was a great work done by John Shamde. These were giants who worked very hard on the infection and how to reduce the infection. This is the German. This is a German surgeon from Endoclinic, that is Buchholz. He is the one who started what is antibiotic cement, Pelagos, and also he is the man who developed the stage 1 surgery for infected. One surgery. Then John Insall, he worked very hard on the knee side as far as this is concerned. Clive Duncan, this is the man who started antibiotic Prostolax cement, that is the antibiotic various spacers and how to prepare the spacers. Woblesky also was a very proponent of the stage 1 surgery from Wrightington Institute. Michael Freeman from UK, London, he also worked very hard on the. And today, the giant man in the infection, everybody should know his name is Javed Parvezi, who has got a great knowledge of infection, and he conducts every 2 to 3 years a very important meeting known as a consensus meeting, and he invites 300 surgeons from across the globe, and he brings on the single platform and prepares what is the protocol, how to reduce infection. The last year itself, the book has been published. So what is the projected growth in the hip is quite high. So these numbers are going to be increase in number of infections are going to be high. So the projected is 174% increase in the hip replacement. More than 4 million joint will be done in USA itself. So imagine by 2030. So the load is going to be very high. What is the incidence of PJI today across the globe? It is 0.25 to 2% within 2 years of THR or TKR, and that causes a problem of prolonged rehabilitation, prolonged therapy, and its side effects. Patients have to go through multiple surgeries. And the results are not that gratifying. The results are poor. Cost to the family and healthcare is going to be a problem. So if you reduce the number of infections, the whole burden will be get reduced. So it's very important. So how do we do it? We'll discuss this by prevention, diagnosis, and how we do the treatment of this peri-prosthetic fractures. Now, pre-operative, we'll start with pre-operative, intraoperative, and post-operative. Pre-operative bacterial decolonization is very important. See, all these patients, you must tell them at least 2 days prior to the surgery, coming to the hospital, they should have a shower bath with antiseptic agent that is 4% chlorhexidine gluconate or with isopropyl alcohol or a medicated soap. And those patients who come to the surgery, suppose they come in the afternoon and evening, they should have 2 baths. One on the night previous and early morning. Only patient with a fractionated femur are the problematic because they can't have. So you need a proper preparation inside this in the operating theater. So I think it is a protocol in most of the Western world, because the pre-operative, all the protocols are worked out. We always tell the patient, the sheet has been given to them, what are the instructions, what are the drugs to be brought, what are the things you have to make arrangement at home. So this is one of the important factors. They should have a 2 days prior bath with a chlorhexidine, and it reduces quite a lot. Second, prophylactic antibiotic. We are using generation 1 or generation 2 cefalozorin and cefuroxime, and because the common organism is staph and stapho, and it will also depend on where you are working actually, what is the setup you are working, and what is the infection control committee has given, which is the antibiotic in your hospital going to work. That is important. So every 2 to 3 years, we our hospital also produces the protocol of what antibiotics to be used. So it is always important that 1 hour before, most of the time, anesthetist forgets and surgeon forgets the antibiotic protocol. So once the patient is healed inside, actually it takes 1 hour before the incision, because the anesthesia and so many. So as the patient is in, I think that is the time the antibiotic should be given. It should not be given 3-4 hours earlier, because the MIC level does not come to the higher level. So very important. And another important thing, we forget the dose of antibiotic. Patient above 80 kg, we can't give just 1.5 gram or 1 gram. So the significant blood loss, double operating time, actually you require a double dose. If the patient is going to get at least 2 or 3 bottles of blood, or is going to get 1,500 fluid, so they will require one more dose. It is important not only on the body weight, also it is a time factor, blood loss, these are the things. And normally you continue antibiotic for 24 hours, or sometimes if the catheter is in, probably you might have to continue for next day or so. Those who are allergic to beta-lactam, I think vancomycin or clindamycin is the drug of choice. One important factor of vancomycin, you can't give just a bolus dose. So this takes about, it is diluted usually 100 or 200 cc of saline, and it has to go slow. That's why it is important that it should be started at least 1 to 1.5 hour to the surgery. So that's vancomycin has a different protocol compared to generation 1 and generation 2 capital. So the other important thing, I think, is the hair removal just prior to the surgery, maybe about a couple of hours, and use the clipper and not the razor. These are very important. Most of the time in olden time, we used to get the shaving done by the razor by the barbers, but today we have stopped this, because you get a lot of abrasion and staphylococcus will just grow in no time. The next is the skin preparation. It's more important, very important. Chlorhexidine is more popular due to long acting of gram-positive and gram-negative bacteria, which are commonly found in the human square flora. So what normally we do it in the patient, when the patient is healed, at the time of preparation, at the time of position, we just do it outside, because there are our preparations or rooms are different and operating room is different. So it almost remains 10 to 15 minutes before the patient is healed inside. So that is very important to keep this chlorhexidine, and just after chlorhexidine, immediately don't take it out, don't wash it out. You have to keep that. So that is the only way it will have an action. Commonly used preparation are chlorhexidine, alcohol-based solution, or povidone. These are both are good as far as the things are concerned. So we have to keep. We do it actually. You have to do it twice. Once in the preparation room, and once the patient is healed inside, and one more preparation of chlorhexidine. That gives a good protection. Then surgeon scrub. Surgeon scrubbing, that is with again chlorhexidine or pyridine, at least 3 minutes for first surgery. And if you are going to operate side by side theater, you are going to just take out a gown, and you are going to the next theater, is 1 minute is okay. But once you go out of the theater, again 3 minutes. So it is usually you should have a scrub for at least for minimum 3 minutes. The draping, usually a non-permeable drapes, that reduces the contamination of infection. Is very important, because we do a lot of lavage wash, and this is a great contamination for a lavage wash if you don't have non-permeable papers. Then surgical skin drape, the iodoprobe impregnated drape has shown antibacterial protection, and one must use it. The next is glove. All surgeons usually have a double glove protection has been recommended. Triple grout decreases the glove perforation, but surgeons are not very friendly. So I think double grout is very friendly as far as the orthoplasties are concerned. Laminar flow may be ideal to use. Lindwell has shown the infection rate has reduced from 3.4 to 1.6 by using laminar. There is some controversy regarding laminar flow, but as far as you are concerned, I think in the exam, the laminar flow theater is ideal for you. The next is maintain the positive pressure ventilation. The filter air through the appropriately filter and 90% with efficiency. So these are the special filters. First, they are microfilter, they are nano filters, and then they are HEPA filters. So that is the way the filtration of the air comes inside. We should use vertical laminar flow from the ceiling and not from the horizontal. We have stopped using horizontal laminar flow because the rate of infection had gone very up. And that is the work of Mr. Salvati from Special Surgery Hospital, New York. So nowhere in the world now, we don't use horizontal laminar flow. It disturbs the flow. And that's why it is called turbulence. The turbulence occurs. No ultraviolet rays in the OT, but it damages the surgeons and as well as the anesthetists and other people. So we have stopped using ultraviolet. And most important, limit the person traffic. That is one important thing. At least for a hip replacement, you have got a 2 or 3, one surgeon, 2 assistant, 1 anesthetist, and there are 1 sister and another 2, not more than 7 to 9 people inside the theater. And door opening is where once you open the door, there is a disturbance of the airflow occurs, and that is the biggest problem that disturbs the laminar flow system. So it is very important to have a limit the person, and traffic should be completely controlled. Personal protection system, 1960, John Chandler introduced the human exhaust system, and it has been controversial as far as this is controversial. OR traffic, look at this. If the door opening, average opening the door in primary joint replacement is 0.65 per minute and revision 0.48 minutes. So contamination rate is directly proportional to OR traffic. So this is very common in our theaters. That instrument is outside. Somebody, the anesthetist wanted to go out. All the continuously goes on. So it is very, very important. So that's why in my protocol in our hospital, once everybody is inside, we just lock the door. Unless there is a very emergency, then we'll have to open it up. Operative time. Risk of PGI increases with the extensive operating time. Low volume surgeon have high infection because they take long time for surgery. This surgery, by and large, primary surgery should be finished in less than 1.5 hours. That is the ideal time. Antibiotic impregnated cement has a lower risk of infection. We don't use routinely, but if you have to use it immunocompromised, diabetic, rheumatoid patient. These are the patients who we have to use what is called antibiotic impregnated. And common antibiotic impregnated cement is gentamicin, that is known as a Palacos, which is available. Wound closure and surgical dressing. Surgery. Controversy regarding stent staple, absorbable suture, knotless barber, and so many things. I think whatever, there's not answered, but whatever you are comfortable, use it. Post-operative. So we looked at the before operation, during surgery, post-operative, post-orthoplasty, antibiotic prophylaxis, efficient bacteremia could be potential risk of PGI. Certain medical procedures are likely to cause bacteremia. And those patients who will go after a couple of years for any other surgical procedure like endoscopy, colonoscopy, they should inform that surgeon that they have an implant inside the body and they should start prophylactic antibiotic. Dental procedure, which is based on the patient risk factor and complexity of the procedure. If they are going to touch the pulp or extraction, these people require antibiotic protocol before 24 hours before. If they are going to do a very minor procedure like scaling or few other things, then they don't need. So anything which get into the pulp will require antibiotic for as far as the dental pathology is concerned. How do we diagnose now? Today, there is no single test yet to be 100% specific and 100% sensitive. So we are working on various things. surgeon judgment, proper decision, all the thing, serum test, histology, frozen, clinical, nuclear scan, and whatnot. So we are going all around to make some diagnosis because there is no single test available. So we need to go all around before we diagnose, and we will see how we can get it. So there are patients who are a risk factor. They are host factors like diabetic, rheumatoid, renal disease, chronic pulmonary disease, valvular disease, metastatic tumor, anemia, VTE, depression, psychosis. Also, people are very high rate of infection. So these are the host factor which are not in our hand. Something is in our hand, but these are not in our hand. So we need to look after them with a proper antibiotic and proper protocol. ASA above grade 2, uncontrolled diabetes, rheumatoid arthritis, significant increase in peri-prosthetic infection. So ASA is also important, and that is the important which the anesthesia department has quantified from grade 1 to grade 5. What are the criteria? Criteria of infection. So Musculoskeletal Society has come out with a proper criteria, and we have to just follow this criteria. One, that is criteria A, sinus tract communicating with prosthesis. This is 100% infection. Once you put a just probe inside, if the metal gets hit it. So, or if you do a scanogram, it is directly getting connected to the joint. So A, important, sinus tract communicating. B, pathogen isolated by culture from 2 or 3 separate tissue, and the organism should be same. So sinus tract or a sinogram leading to the joint. This is the sinogram going inside the joint and towards the implant, and that is the way we track this 100% infection. Second is pathogenesis isolated culture from 2 or more separate tissue or fluid sample, and organism has to be the same. The third C, and the C is, out of this, these are the things which I'm going to describe. Out of this, 4 out of 6, then it is a definitely infection possibility. One is elevated meeting is Chintan.
Sir. Yes, sir. Yes, sir. Yes, sir.
Timing का problem, you have to see the timing and we'll have to again do it.
Yes, sir. अगर end हो जाता है तो आप वापस से create करें.
Okay.
Yes, sir.
So let me know.
Okay, sir. Done, sir.
Elevated ESR and CRP, both should be elevated. Elevated synovial white cell counts, elevated synovial polymorphs, which are more than 80 to 90% polymorphs. Presence of purulent in affected joint. Number 5, isolated microorganism in one culture of the tissue fluid, and greater than 5 neutrophils per high fiber in the histology. Out of this 6, if there are 4 positive, then it is infected. So sinus, orthography, culture of the 2 specimens, and these out of 6, 4 has to be positive, then it becomes a definitely infected. So the root of PGI, where the infection comes. One is exogenous during the surgery, that or short after immediately after the surgery. This is the commonest, which is the infection. So exogenous infection during surgery, this is the most common. Hematogenous infection occurs late, after some time. Sometimes after 2 years, patient develop a urinary tract infection and develop a metastatic infection, or he develop an abscess somewhere else in the body, and then it is get contaminated, and that is called hematogenous. This usually occurs after a year or 2 or 3 usually. So the commonest route for is exogenous during the surgery or shortly after the surgery. So how do you classify this infection? Early, post-operative, within 4 to 6 weeks after the surgery, and you have to blame yourself. 2 is delayed 3 months to 24 hours post-op. That is also you have contaminated most of the time. And the third is not in your hand. That is called late onset after 2 years, often due to this is well-functioning joint and suddenly after 2 years the patient lands with infection. These are usually metastatic or hematogenous infection. That is not a surgeon fault at all. So up to 2 years, it is your responsibility. You have contaminated that joint. Maybe it was a low grade and it has now organisms has come up. This is something new, a silent. You are doing a revision surgery, patient counts where everything was fine, and you are doing a revision surgery, and you are routinely we send a culture, and that becomes a positive. That is called silent. That is a fourth type, a positive culture at the time of revision with no history of previous infection, and they were all markers were fine. So this is the four types we do have this. So hematology worker, ESR is a lack of specificity and sensitivity. So just ESR has no meaning, much more meaning. CRP are more valuable, and if you look at the combination of both, it is very good. The combination of CRP ESR is more reliable. If patient has got a ESR 20 and CRP less than 5, you can sleep well that this patient is non-infected. Normal value results definitely rules out the infection. This is one important landmark for all of you. Interleukin level. Interleukin level is not commonly done, but it is more sensitive than ESR, ESR and CRP. Unfortunately, this is a costly investigation and will not be doing very regularly in this country. I think there are only 2 centers in Mumbai. They do interleukin level. There's one is the Hinduja Hospital. They do routinely interleukin level. Then pro-calcitration level, sometimes when we are missing something, then we do it rarely pro-calcitration, but this is not very reliable. It actually shows acute infection pro-calcitration. So that about the investigation. We will come to the special investigations little later. Radiographic evaluation, plain X-ray are usually not diagnostic in initial phase. Once you develop a periosteal reaction, that means already it is a gross infection. So if you look at the carefully in this patient, you see this is a periosteal reaction. This is a classical sign, and it always pathognomonic of infection. Endosterial erosion, see the endosterial erosions. These are endosterial erosion here, and a periosteal reaction here. They are very diagnostic of infection. You can 100% say that is an infected joint. Next is ultrasonography. Joint fluid distension, capsular thickening more than 10, and any fluid which has crossed the compartment is diagnostic of infection. This is one important message for all of you. So if your ultrasound man is good and he can read well, he will be able to, without even MRI anything, we will be able to diagnose infection, because compartment breakage is very important sign of infection. CT tomography, soft tissue collection in the muscle and pericapsular area, it 100% predictive value, something like again ultrasound. Absence of joint fluid, 96% negative predictive value. If there is nothing in the joint fluid, I think you can enjoy it. Periostitis on CT scan is 100% specific for infection. So CT break in the compartment, very important. Periostitis 100%, and only when the joint fluid is not there, you can always definitely tell 96% chance that this patient is not infected. Normal fluid is 2 to 5 ml is always there, but there is nothing distinction. You can forget about this is not infected here.
Sir.
Then we okay.
Sir, we are joining in new room, sir. We are ending this meeting.
Okay.
Okay, sir. Okay, sir. Yes.
WhatsApp किया है सर लिंक?
WhatsApp किया है सर.
Yeah. Okay.
Okay, sir. Okay, sir.